Welcome back to Beyond the Stethoscope, the podcast for general practitioners. For all of you GPs and registrars out there working hard in primary care, especially those preparing for the fellowship exams, we've got another, well, really vital deep dive for you today.
That's right. Today we're really focusing in on Chapter 75 of John Murtaugh's General Practice, the 8th edition. It's, a real cornerstone for getting to grips with cardiovascular disease, or CVD.
Yeah.
And our aim today is to really pull apart the key bits, defining what CVD actually is, understanding its, massive impact on our patients and the community, identifying those crucial risk factors, breaking them down a bit, and then looking at how we screen effectively.
Absolutely. And we'll be keeping a close eye on what's most relevant for, everyday practice, but also for those really important exams.
Exactly. Because, as you know, CVD isn't just theory. It's the #1 killer globally, and a huge challenge right here in Australia.
It really is. And well, it's good to acknowledge the drop in death rates over the last few decades, which is great thanks to public health stuff and better treatments.
Definitely.
It just highlights that we constantly need to be on top of prevention and management in our clinics.
Couldn't agree more. And our discussion today, it's all anchored firmly in the practical advice from Murtaugh's Chapter 75. So maybe let's start right at the beginning. When we say cardiovascular disease, what exactly are we talking about?
Okay, yeah, let's unpack that. So Murtaugh's lays out three main categories, really. First, and probably the biggest one, is coronary heart disease. At its core, that's about myocardial ischemia, basically. Not enough blood getting to the heart muscle itself.
Right.
And this covers the acute stuff, like heart attacks, myocardial infarction, which Murtaugh covers in Chapter 30, actually, but also the chronic side, like angina, and the long-term picture of heart failure, which is Chapter 76. So it's both the sudden emergencies and that slower decline.
Okay. And the second category?
Second is cerebrovascular disease. So that's strokes and TIAs, transient ischemic attacks, or mini strokes. Chapter 121 goes into detail on those.
Got it. Strokes and TIAs.
And the third main area is peripheral vascular disease. That's where the blood flow to the limbs, arms and legs is compromised. Murtaugh covers that in Chapter 55.
Okay. So coronary heart disease, cerebrovascular, peripheral vascular. And it's really important, as you said, to remember that within that group, coronary heart disease is the single biggest cause of death worldwide.
Exactly. It's the result of those narrowed or blocked arteries stopping the heart getting the blood it needs. And the stats really show the scale of it. The chapter mentions that in Australia, back in 2017, CVD caused 18% of all deaths.
18%. That's almost 1 in 5.
Yeah. And what's really striking when you look back is the historical context. Go back to 1968, and CVD was responsible for like 45% of deaths.
45. Wow.
And the death rate specifically from myocardial infarction, it was about 10 times higher than it is now.
10 times. That really puts the progress into perspective, doesn't it?
It absolutely does. And the chapter credits this huge reduction to a few key things. Definitely public health campaigns, especially the big drop in smoking rates. That's been massive.
Huge impact.
But also, better preventative care. We're much better at managing blood pressure, using statins for cholesterol. Plus, the actual emergency treatment for heart attacks is just way better now.
Which all underlines that critical point. We've come a long way, yes, but we absolutely can't take our foot off the pedal.
No way.
Murtaugh really stresses that our continued focus has to be on helping patients change those risky behaviors, promoting healthy habits generally. That's essential to keep these positive trends going.
Totally agree. So let's shift gear a bit and look at what we as GPs can really get our teeth into, the risk factors for CVD. Murtaugh splits them into modifiable things we can change and non-modifiable, which is a really useful way to think about it in clinic, isn't it?
It really is a practical framework. So starting with the modifiable ones, the things we can potentially influence. First up is hypertension, high blood pressure. And as the chapter notes, that's a massive topic itself, covered in Chapter 77.
Right, worth remembering that link.
Definitely. Yeah. Then there's dyslipidemia, abnormal blood fats, essentially. Again, another big area. Chapter 70 goes into all the detail there. So keep those chapters in mind for the background.
Okay. Then smoking, obviously huge. Chapter 12 covers smoking cessation in detail. But the stat here is pretty stark, isn't it?
It is. The death rate from coronary heart disease for smokers is roughly double that of non-smokers.
Double. That really hammers home why quitting smoking has to be priority #1 for any smoker when we're talking CVD risk.
Absolutely. Next on the list is diabetes mellitus, especially if there's microalbuminuria present, that early sign of kidney trouble. That's discussed back in Chapter 11.
Okay.
Then obesity. Another major player, and it gets its own chapter, chapter 80, it impacts cardiovascular health in so many ways.
Hmm.
And we also have to actively think about sedentary lifestyle, just not moving enough. In our modern world, that's a growing problem, a big contributor.
Definitely feels like it. And what about alcohol?
Yes, alcohol excess, also mentioned in Chapter 12 alongside smoking. The book gives some specific guidance on low-risk drinking. Max 2 standard drinks a day for most people.
Right.
But it drops to just 1 standard drink a day for women who also have hypertension.
Okay, that's an important distinction. Good to have those clear limits.
Very important to be specific with patients. Then there's poor nutrition, covered in Chapter 5. The big things here are cutting down saturated and trans fats,
Yeah.
and salt-sodium intake should be no more than 4 grams a day.
4 grams of salt. Okay.
Yeah, Murtaugh suggests something like a low-carb, healthy-fat Mediterranean-style diet, and wisely points us towards using resources like the Heart Foundation or referring to dietitians for that really tailored advice.
Good practical tips. And finally, in the modifiable list.
Mental stress. Chapter 70 explores this. It's such an important reminder of that mind-body connection, isn't it? Managing stress is definitely part of looking after your heart health.
It really is. Okay, so those are the things we can work on changing. What about the non-modifiable factors, the ones we can't change but still need to factor in?
Right. So these include having a family history of premature CVD. That can give us a clue about genetic risk.
Yep.
Increasing age. Simply getting older increases the risk naturally.
Hmm.
Male gender is also listed. Men tend to get CVD earlier than women, generally
Yep.
speaking.
Okay.
And finally, social histories, things like cultural background, ethnicity can also play a role, often through a mix of genetics and environment.
And the chapter also flags related conditions, specifically chronic kidney disease, CKD, especially with microalbuminuria. That's chapter 79.
Yeah, it highlights how interconnected everything is. Kidney problems impacting heart health.
Exactly. So we've got this list of risk factors, modifiable and non-modifiable. The next logical step in practice is actually assessing someone's overall or absolute cardiovascular risk.
Precisely. Murtaugh stresses how important it is to estimate a patient's risk of having a major cardiovascular event over the next 5 years, sometimes even 10 years.
And this assessment, this number, it really guides our decisions, doesn't it? Whether to start preventative meds, what screening tests are needed, how intensive the management plan should be.
Absolutely. It's foundational. And the chapter gives clear guidance on who needs regular reassessment specifically every 2 years.
Okay, who falls into that group?
So that's all adults aged 45 and over who don't already have known CVD.
Right.
And importantly, Aboriginal and Torres Strait Islander people from the younger age of 35 years.
Okay, 45 generally, 35 for Aboriginal and Torres Strait Islander adults. Crucial ages to remember.
Very crucial. And Murtaugh also points out that some people are just automatically classed as high risk. They don't necessarily need a formal risk calculation using tools like Framingham.
Oh, okay. Who are they?
Anyone with established CVD already say they've had a heart attack or stroke.
Bruh.
Also, anyone over 60 who has diabetes.
Right.
And pretty much anyone with diagnosed hypertension.
Right.
Their risk is already considered high, so management needs to reflect that from the get-go.
Got it. That makes sense. So that leads us nicely into the specific screening we should be doing routinely in general practice.
Exactly. Blood pressure first. That's fundamental. Measure it in all adults from age 18, at least every couple of years. Basic screening for hypertension, indicator of CVD risk.
Standard practice, yeah. What about lipids?
For blood lipids, the recommendation is usually to start with a fasting lipid profile at age 45.
Okay.
Then repeat it every 5 years if the risk is low to moderate. But again, for Aboriginal and Torres Strait Islander patients, start that screening earlier, from age 35.
35 for lipids too. Okay. And is fasting essential?
Well, the chapter mentions that non-fasting lipids are an acceptable alternative if fasting is proving difficult for the patient. Practical point there.
Good to know. Diabetes screening.
For diabetes, use fasting glucose or HbA1c. Screen every 3 years, starting from age 40.
40, okay.
But again, that crucial earlier start for Aboriginal and Torres Strait Islander people from 18 years old for diabetes screening.
Wow, 18. That's a big difference. Really important to catch that.
Absolutely vital. And then for kidney disease, if someone's identified as high risk, screen them every 1 to 2 years using the ACR albumin creatinine ratio and eGFR.
Okay. Now, the chapter makes an interesting point about the risk calculators themselves, doesn't it?
It does. It notes that things we know are important risk factors, like BMI, ethnicity, or being sedentary, often aren't directly plugged into the formulas of those calculators, like the ones in figures 75.1 and 75.2.
Right.
But as GPs, we still absolutely need to consider them in our overall assessment, and definitely when we're giving lifestyle advice. They still matter, even if they're not in the calculation.
That's a really important practical point. And those figures you mentioned, 75.1 and 75.2 in Murtaugh, they are pretty handy, quick guides, aren't they?
They really are. They lay out the risk estimates based on things like blood pressure, diabetes status, smoking, cholesterol ratios, age, sex. One for people without diabetes, one for people with. Definitely worth spending some time familiarizing yourself with those for exams and clinic.
Good tip. Okay, let's move on to secondary prevention. So, managing people who are already known to be at higher risk or who've actually had a cardiovascular event.
Right. And Murtaugh is crystal clear here. Addressing lifestyle and behavior is fundamental for these patients. Every single person with risk factors needs that personalized, practical lifestyle advice.
And it introduces the 5A framework, that's from chapter 12, I think,
Yep.
as a way for us GPs to structure that conversation and support change.
Exactly. The 5 A's. Ask about the behavior, advise on changing it, agree on goals, assist with help and resources, and arrange follow-up. It's a really useful structure.
So how does that apply to the specific risk factors? Smoking first.
For smoking, the goal is simple. Complete quitting. Stop smoking altogether and avoid secondhand smoke too. And remembering that doubled CHD death rate just reinforces why we need to be persistent and supportive with cessation.
Absolutely. Alcohol.
Same advice as before, really. Keep it within those low-risk limits.
Mm.
Max 2 standard drinks a day generally, or just one for women with hypertension.
Okay. Nutrition.
Focus is on healthy eating patterns. Limiting those saturated and trans fats, keeping salt under 4 grams a day. That Mediterranean-style diet gets another mention.
Right?
And again, use resources like the Heart Foundation. Refer to dietitians. Don't try to do it all yourself.
Good point. Physical activity.
The target is at least 30 minutes of moderate intensity activity most days of the week, aiming for a minimum total of 150 minutes per week.
150 minutes, okay.
And think about referring. Exercise physiologists could be great. Local community programs too. Whatever helps the patient get moving safely.
Makes sense. What about weight management part?
Healthy weight is key. Murtaugh gives target waist measurements under 94 centimeters for men, under 80 centimeters for women, and the standard healthy BMI range of 18.5 to 25.
Okay.
And it's worth stressing to patients that even losing a bit of weight can make a big difference to things like insulin resistance and their lipid profile. Chapter 80 has more detail on obesity management.
Right. And the last lifestyle bit was stress.
Yes, managing mental stress. Encourage relaxation, recreation, meditation maybe, building good social support, and crucially, identifying and treating anxiety or depression if they're present.
Okay, so that's the lifestyle side, covered pretty comprehensively. Now, what about the biomedical targets, the actual numbers we're aiming for in high-risk patients? Murtaugh defines high risk as over 15% 5-year risk, or previous event, right?
That's the general threshold, yes.
Yeah.
So for blood pressure in these folks, the target is usually less than 130 over 80.
Less than 130/80.
Though, always check the latest specific hypertension guidelines too, as targets can sometimes be individualized.
Good caveat. Lipids. The targets seem quite strict here.
They are quite tight for high-risk individuals. Total cholesterol less than 4 millimoles per liter. LDL cholesterol, the bad one, less than 2.
Under 2 for LDL.
Okay, HDL, the good one, should be 1.0 or higher. Non-HDL cholesterol, less than 2.5. And triglycerides, ideally below 2.0.
Wow, lots of numbers there.
There are, but the main focus really is driving down that LDL cholesterol.
Right. And the chapter makes a really powerful point about that, doesn't it? About the mortality benefit.
It does. It highlights that for every 1 millimole drop you achieve in LDL-C, you get about a 10% relative reduction in all-cause mortality.
10%. That's significant. Really shows why aggressive lipid lowering is so important in this group.
Absolutely. Now, for patients with diabetes in this high-risk category, what are the glucose targets?
The aim is optimal control. Ideally, fasting blood glucose between 4.0 and 6.0 millimole.
Okay, 4 to 6 fasting.
Although, as the text notes, some guidelines like NHMRC might give a slightly wider range, maybe 6.1 to 8.0. But aiming lower is generally better for CV risk. And the HbA1c target is usually 7% or less. Again, check specific diabetes guidelines.
Got it. And finally, antiplatelets, aspirin.
Right. Aspirin low dose, 75 to 150 milligram daily. It's generally recommended for secondary prevention, so patients who've already had a CV event like a heart attack or stroke, assuming no contraindication.
Okay, secondary prevention, yes.
But, and this is really important, the evidence for using it in primary prevention people who haven't had an event yet is much weaker. It's generally not routinely recommended anymore for primary prevention, even if someone is high risk or has diabetes, because the bleeding risk often outweighs the small benefit.
That's a key update in practice over recent years, isn't it?
Yeah,
Less aspirin for primary prevention.
definitely. And before we wrap up, Murtaugh also mentions a key resource.
Ah, yes. The National Vascular Disease Prevention Alliance guidelines
Mm.
usually provides a link. That's a really comprehensive, evidence-based resource,
hmm
definitely worth bookmarking and digging into for more detail.
Absolutely. Okay, so just to quickly pull it all together from our deep dive into Chapter 75 today, we've looked at what CVD actually is, coronary heart disease being the big one.
Yep.
We've seen the huge burden it places on Australia, but also the encouraging progress made in reducing deaths.
We then spent a good chunk of time on the risk factors, both the ones we can change, the modifiable ones like smoking, diet,
Yeah.
exercise, BP, lipids, and the non-modifiable ones like age and family history.
Yeah.
Identifying and managing these is just critical.
And then we talked about absolute cardiovascular risk assessment, using those scores to guide our prevention strategies, and the key screening tests we should be doing in practice: BP, lipids, diabetes checks, kidney checks for some.
And finally, we covered secondary prevention for those already at high risk. The vital importance of lifestyle changes. The 5A's framework is great there, and those specific biomedical targets for BP, lipids, and glucose, plus the nuanced role of aspirin.
It's all incredibly practical information straight from Murtaugh's really core stuff for day-to-day general practice, and of course, absolutely essential knowledge if you're prepping for fellowship exams. The GP's role in preventing and managing CVD is just, well, it's central, isn't it?
It really is. Which leads us, I suppose, to a final thought for you, our listeners, to reflect on. How are you currently tackling CVD risk assessment and management in your own practice? And thinking about everything we've discussed today, based on Murtaugh, is there maybe one specific doable change you could bring into your routine to enhance how you manage CVD prevention?
That's a great challenge, something concrete to take away. And we really do encourage you to go back to those referenced chapters in Murtaugh, maybe check out those NVDPA guidelines online, just to really solidify your understanding.
Definitely worth the time.
Well, thank you for joining us for this deep dive on Beyond the Stethoscope, the podcast for general practitioners. We really hope it's been useful and given you some valuable insights. We'll catch you on the next one.